Focusing on hypertrophy, many of the systems which I outlined earlier, so the autonomic system, the renin-angiotensin-aldosterone system, which have effects in the early adaptation to heart disease, also feed into the changes within the heart muscle that occur. And remodelling broadly is a term where any change in either the structure or constituents of the myocardium, so changes in heart chambers particularly, are referred to as remodelling. And generally, remodelling as a consequence of cardiac disease is thought to be a detrimental process. The heart itself is actually a very naturally sort of plastic organ. It can change in its shape and function and constituents. And a great example of that is athletic training. In athletic training, the changes that occur in the heart are generally beneficial and an adaptation to the demands of the body, whereas unfortunately the adaptations that happen in disease, although initially favourable, are ultimately likely to be detrimental. And so the main stimuli for these changes are probably chronic adrenergic stimulation, angiotensin II and aldosterone, although there are multiple other factors that are involved too. Now, we've been looking, among other things, in some research work at a relationship between, for instance, some of the markers I've been talking about, or some of the hormones I've been talking about, and heart size. And we've found in dogs with valvular heart disease quite a clear relationship, certainly it's quite a significant relationship, between the aldosterone concentration and heart size in dogs with valvular heart disease. Now, whether that's coincidental, whether as the disease progresses one gets bigger and the other goes up, or whether that's a direct cause and effect relationship, I don't think we can really say. The other confounding influence in heart disease is that in the later stages of heart disease, typically dogs are treated for their disease process, and some of the treatments that they receive tend to increase aldosterone. But it does seem to be that we've can see a relationship between aldosterone concentration and heart size in the later stages of heart disease. Another hormone system, and something I haven't talked about yet, but of a lot of relevance from the sort of diagnostic point of view, are the natriuretic peptides and the natriuretic peptide system. Natriuretic peptides are peptides that are manufactured within the heart and released in an effort to actually counteract the volume expansion that's brought about by aldosterone, among other things. So what the natriuretic peptides try to do is to get the body to excrete more sodium. And the natriuretic peptides are released from the heart when heart muscle is subject to increased stress. And increased wall stress is brought about typically by increased heart size and increased filling pressure. So what we see is quite a clear relationship between severity of heart disease and advanced stages of heart disease and natriuretic peptide concentrations. Now, unfortunately, the favourable effects that natriuretic peptides are trying to bring about are overwhelmed by the volume retaining systems like aldosterone and ADH. But the natriuretic peptide concentrations are quite a good marker of the severity of the disease, and actually increasingly are being used for diagnostic purposes because of that. Higher concentrations tend to indicate more severe disease, and we can therefore probably diagnose heart failure in dogs by measuring them. So the theme which it comes across in any examination of these different systems is that the disease comes along and the disease initiates an adaptive response. And that adaptive response in the short term may well lead to favourable effects such as expansion of the circulating fluid volume through the Starling effect, increasing cardiac output, things that the cardiovascular system wants in order to be able to adapt. Unfortunately, though, what heart disease does is it means that those systems are never inactivated. And it's the chronic activation of those systems ultimately leads to a detrimental effect. So we go through a stage of adaptation through a maladaptive response, and ultimately that maladaptive response, in many cases, may lead to the progression of the disease. So if we think about mitral regurgitation, and with a series of diagrams here, what I'm just going to do is outline an initial response to mitral regurgitation, so an acute response to mitral regurgitation, followed by a chronic response, and then ultimately decompensation. These pictures and these numbers are taken from a paper about human patients, but are helpful in an illustrative way to look at how the heart responds to the disease process. So if we take a normal heart, as I said earlier, what happens is a normal heart, every time the left ventricle contracts, all of the blood ejected from that ventricle is ejected into the aorta. If we take the rather artificial situation where a patient acutely developed mitral regurgitation, then each time the ventricle contracts, a large volume of blood is ejected back into the left atrium and a smaller volume than normal is ejected into the aorta. Now, what that will lead to is a fall in arterial filling pressures and a fall in cardiac output, which stimulates the adaptive response. But it will also lead to quite a marked elevation of left atrial pressure because suddenly there's a large regurgitant volume of blood that is going back into the left atrium. Now, if we look at the diagram here, in the first diagram, the one that appears on the top right, what we can see is that suddenly left atrial pressure in a patient that's developed acute mitral regurgitation has jumped from a normal value of about 10 to a value of about 25. Now, if that happens acutely, that's probably enough for pulmonary venous congestion and potentially pulmonary edema to occur because the elevated left atrial pressure impairs the drainage of blood into the left atrium. What we can also see comparing the normal diagram to the acute regurgitation diagram is that the volume of blood being ejected into the aorta has fallen from 100 mils every time the heart contracts to 70 mils every time the heart contracts. But unfortunately, every time the heart contracts, there is also 70 mils of blood being ejected back into the left atrium. So the left ventricle started out in total ejecting 100 mils of blood. Now it's ejecting 140 mils of blood, of which only 70 are going into the aorta. So we can already see the ventricle is having to eject more blood. Some of it's going into the atrium and causing elevated left atrial pressure, and yet not enough of it's going into the aorta. Now, what then happens, and if we look at the diagram beneath the diagram demonstrating acute mitral regurgitation, chronically, the heart adapts. One of the ways in which it most obviously adapts is by increasing its end diastolic volume. That's how big it is before it starts to contract. So comparing the acute mitral regurgitation diagram to the chronic diagram, we can see the end diastolic volume's gone from 170 mils in the acute situation to 240 mils in the chronic situation. So the heart is bigger, it can pump more blood. The left atrium has also adapted to the regurgitant volume that it receives, again by increasing in size. The left atrium simply stretches typically in that situation. And so the left atrial pressure has fallen despite the fact that there's still quite a significant volume of regurgitation. But the net effect is, with this bigger ventricle pumping more blood, more of it is now being ejected into the aorta. So if we look at the amount of blood being ejected into the aorta, that's up now to 95 mils. It's nearly got back to the value when the heart was normal. And this heart is compensated, quite well compensated, because the ejection is nearly normal. But the net effect is that it has only compensated by pumping more blood and by becoming bigger. Now that process of adaptation may well work for months or for years, where patients remain well compensated for their disease in the absence of any clinical signs, but with a large regurgitant volume. But chronically, for some reason, in some patients, not all, that state of chronic compensation eventually leads to failure of the myocardium. And that failure of the myocardium is characterized by a worsening of the output of blood into the aorta and a worsening of the mitral regurgitation and an increase in the left atrial pressure again. So if we look at the final diagram of the chronic decompensated mitral regurgitation, we can see here that left atrial pressures have gone back up. The forward stroke volume being ejected into the aorta has fallen again, and this is a heart that is badly failing. And what's really most fascinating is about how both clinically and from a neuroendocrine point of view, we can characterize that process of adaptation and then maladaptation. Now, what we can see from a clinical point of view is that there are some simple measures of severity of disease which we can detect without any fancy ancillary diagnostic tests, which correlate roughly with the severity of the disease and the adaptive process that goes on. And looking at this graph, which we've got here, there was a very nice study that was done where simply the investigators correlated the intensity of audible heart murmur with heart size. And one measure, and the measure that's illustrated on this graph here, is left atrial to aortic ratio, and another measure here is left ventricular end diastolic diameter. What we can see here is that normal dogs and dogs with low intensity murmurs have very comparable ventricular diameters and very comparable left atrial to aortic ratio. But as an animal's murmur becomes more intense, if we look at the medium category and the high intensity category, we can see that they have larger left ventricles and larger left atria. So simply listening to a dog with valvular heart disease, the more intense the murmur, the more likely it is that the disease is at a more progressed stage, and probably the more likely it is that it has an enlarged heart. Now, we have various mechanisms whereby we can actually characterize the extent to which the heart enlarges, and one of the ones which is most widely available and used quite rightly very frequently in these patients is thoracic radiography. So if we look at these series of 4 thoracic radiographs, these all came from the same patient. And the image which is on the top left was taken from that dog on one of the earliest occasions that I saw it, and as we can see from the dates on here, that was back in 1999. The subsequent 3 images were taken over a period of several years until the lower right image, which was taken in 2004, is an image that was taken when the dog eventually went into heart failure. And you can see through this sequence of radiographs that the heart quite clearly enlarges. It enlarges prior to the development of heart failure, but in that final bottom right radiograph, there's also quite clear evidence of pulmonary edema and pulmonary venous congestion on the radiograph. And that's the end result. So the heart increases in size. We can imagine that the patient remains well compensated for their disease until eventually they decompensate, which we can see radiographically. So there are a few controversies that remain in this disease process. One of them is exactly what mechanisms underlie and in what process they are activated, exactly what mechanisms underlie this remodelling process. There have been some studies which have been done looking at experimentally induced mitral regurgitation, and what they seem to show is that the acute response to mitral regurgitation is actually characterized by dissolution of collagen and a decrease in the amount of fibrosis within the myocardium. Now, what we don't know is that because this is a relatively artificial disease process. Now, looking at these 3 diagrams, which are reproduced here from an article looking at experimental regurgitation, one of the things which we can see is, particularly if we look at the top diagram here, is that the percent of left ventricular collagen, which is an indication of the degree of fibrosis, actually reduces in the acute adaptation to a large mitral regurgitant jet. That seems to be mediated by the activation of enzymes which dissolve collagen, and it may be that there's a role for mast cells in this. But one of the reasons this has caused a lot of controversy is that it's not really comparable looking over a period of weeks or months at an animal that's artificially had a large regurgitant volume induced. It's not really comparable to the natural disease state, which is typically characterized by elderly dogs that start with small leaks and that progress over several years. So that's one area which I think really is currently undecided. Another area which is controversial and undecided is any role that inflammation may have to play in the progression of the disease process. Certainly in human patients in the late stages of heart disease and heart failure, it's very well demonstrated that inflammation underlies some of the eventual progressive changes, particularly, for instance, the development of cardiac cachexia. The slide which I'm showing here basically illustrates a study that was done in human patients, but with mitral regurgitation as their primary disease process, so comparable to the canine disease that we see. In this disease, what they did was they operated on human patients, as they do, they replaced their valve, and they looked at inflammatory cytokine expression in the heart before and then after replacement of the valve. So before and then after an intervention which improves heart function and reverses some of the changes that occur. And actually what was shown very nicely was that before undergoing surgery, there was a much greater expression of TNF-alpha, an inflammatory cytokine, than there was afterwards. So there's lots of bits of the story that we've yet to really unpick, but what is quite clear is that disease process that occur in dogs is characterized by neuroendocrine stimulation, progressive enlargement of the heart, leading to retention of fluid, and that retention of the fluid eventually overwhelming the capacity of the heart to compensate for the disease process, resulting in increased left atrial pressures, pulmonary congestion, pulmonary edema, and the signs which we recognize as being congestive heart failure.